was to introduce an efficiency in healthcare. So yeah, this has been, I was just at the very beginning was saying that it has been a significant concern for all policymakers and healthcare providers as well. So, and one of the reasons is, of course, definitely that there has been a lot of demand for healthcare services, and we are limited by the resources. And the need for the expenditure in the healthcare is also there, that given that we have to serve the population, not only in terms of the demand for services for the increasing population, but particularly in urban health context, as this Chorus project is about, mostly in urban health context, with the particularly the rising population, urbanization, and also like the type of health facilities that exist in urban context are so numerous, and there are different kind of actors. So that's an important for the policymakers. Of course, as we know, the desirable goals is to kind of in the health system goals are there, that we want to improve the health system as such. So which has different areas, and one of the particular areas we say that, well, for improvement of the health sectors is like a good stewardship, which means that good use of available resources and reduce of wastage. So that will also, in this context, studying the efficiency, and if we want to attain this efficiency of the healthcare system is important. And also, like, the researchers using these measures of efficiency can really help to kind of design or kind of what they want to really bring up with their policy brief to the policymakers. So if you want to say that, well, this is the situation in this country in urban health system context, but of course, to really kind of a substantiate with our arguments putting forward that we need to improve the efficiency, so that helps us. If we know the measure of efficiency, we can take to the policymakers that, well, these are the way we have measured it, and then there is a need to take some policy. So and the decision makers are doing that. So just to kind of start with the definition. So next slide, yes, and it's a concern with the relationship between resources and the inputs, cost, and the form of. So the inputs, as we know that, in case of form of labor, means the health personnel, like, doctors, nurses, and other healthcare service providers are engaged directly or indirectly in providing services. The amount of money you spend on them. So it's all the inputs and also the investment we're making on capital equipments. And these inputs could be either intermediate, and then what we say that, well, if you have these inputs, we're trying to kind of in the relationship, what are the relationship between these inputs and outputs, which could be intermediate or final health outcome. So we normally say that, well, intermediate outputs may be the number treated, treated at outpatient, or what was the waiting time, what is the number of contacts or number of just like, for example, antenatal care provided, postnatal care provided, delivery care provided, some of these. But final outcome may be possible as well. So we want to find out the relationship between the inputs, not only the intermediate outputs, but also the final outcome, where we say that, well, any interventions through the facilities or within the health system that we are really taking into consideration for the study of the efficiency, where we can really measure the life saved and life years gained. So this is a basic definition and the premise we start when we really look at the efficiency analysis in the health sector. So the next slide, Zahid. And to really start with just how we say that relationship. So the relationship, as we say that in the vertical or the y-axis, is that output, and we say that really input is, well, L and K normally we use at the labor and capital. So with the transformation of input valued as an output denotes in a production function, which always try to show that in a production function, so which indicates the maximum feasible level of output for a given set of inputs. That is what we show in the production function. That means that how do we transform the inputs into to a valid outputs, and that is indicates a maximum feasible level of output for a given set of inputs. Of course, we know that these are the problems and how your production function would look like. So taking that production function into another simple two inputs and the production possibility, what we call production possibility frontier. So that you have a combination of two inputs, and then you can use these two inputs at a different combination and can achieve, as we just mentioned in the production function, the maximum possible that may be available in output that can be attainable. So that's the frontier which we can see dark, the concave line we can see as shown on the left hand side of the diagram. So so that is a kind of a sense. Anybody, any combination or any level of output which is below this frontier would be a point of inefficient point, which means you are using a certain level of the combination of two inputs, but it is possible that you can achieve and move to a frontier. So and in the long run, I mean, that is another thing, is that we can't say that this is your frontier given, so you have to really work within that, which is that's it. So that's the kind of thing which is within the long-term increase in the production possibility frontier. The right-hand side, which is again telling the more or less the same story, where we kind of try to show that the level of the level of production is given by what we call isoquant, which means an equal level of output is given by SS, which is again marked here as the production function is the output is a function of these two input and x1 and x2, which is given in the vertical axis and also the horizontal axis with a given of this shows is an output of y. So and then this we normally, when we say that, well, this is the thing, and the isoquant means an equal level of production is then brought in together with the given the combination, of course, given that you're constrained that what is your possible, the resources are available, and then and if you spend all your resources in one particular and in one particular type of inputs, and if you spend all of those, so you can say, well, all OA, so that all resources is spent on X2 and another one. So that's and then we have these production possibility, which is now shown as an equal level of output, and that's also given here. So what the reason I'm trying to bring it here is to kind of say, as a combination of these two inputs, and like it's shown in OP, and then and clearly the P point is a combination of inputs where if it is observed that we are at that level is an inefficient combination because you are not possible to, I mean, the output level is Q, but whereas you can achieve that level of output having a combination of inputs are lower than that. So it's not the reason. I'm just trying to bring this, that you have to really go and understand all these things, which normally we give in the lecture in economics. But the good thing, the important thing is to understand in this efficiency analysis is that you have a given, and Zahid will explain how much more how difficult and complicated to take it in the real world. So given the inputs you have, and given that inputs is because of these given resource constraint, and you have a technology in the combination of these two, and the maximum possible attainable output, you just look at it, and within the resource constraint, and see what happens where you can be, so that you can maximize your output. But at the same time, we also tell something that what will really happen, that with in the short run, the technology, and you can't really, that with a given combination of the technology changes, so your production function of the production possibility frontier, that it's a possible maximum possible attainable output is also changing because of the technology changes, and then whether you can adopt or whether to that changes and can have a different level of efficiency. So most important things we have to really, and there are some assumptions around that. What is the relationship as also between that inputs and output, whether this is a really straightforward kind of a one-to-one relationship, that one proportion, the same proportion of the inputs increase and making a same constant level of output proportion. So it's linear, whether this is really, whether it's so it all depends upon what really happens, and all your estimation, which is different methods of estimation, you can do that. So just to kind of give you this kind of an outlet. So next slide, Zahid. So these are the two types of efficiency we normally see in the theoretical, and it's very useful to kind of have a grasp of it to really understand when we start to do something on efficiency analysis. So I have already mentioned a number of times the definitions about the efficiency. That means you're producing maximum amount of output for a given amount of inputs, or alternatively producing, you can say also they're producing a given output with the minimum input quantities. So such that when a firm is technically efficient, it operates on its production frontier, just what I mentioned. On the other hand, we rarely excite allocative efficiency occurs when the inputs mix is just, which minimizes the cost. So you can just, the previous example in the diagram is just saying a very easy, simple two inputs and saying that one output. So in a situation, in real world situation, you may be facing the situation that you are producing a different type of outputs with a combination of a different type of inputs. The basis is that the input mix is that it minimizes the cost and given input prices, or alternately when output mix is that which maximizes the revenue, that means given the output price. So these are the things which we normally take into account and try to interpret whatever the methods we measure we use or methods we use to really study the efficiency of either at a health system or at a facility level. So Zahid, next slide, please. So just to kind of start with the kind of why we measure and what is the important things you need to really consider. So and then to do that, say, okay, what are the possible reasons of inefficiency? So it could be any failure to attain the maximum is an indication of efficiency, that we can't be there. We should be on the frontier, production possibility frontier. So what are the reasons why, if there is any failure? So any failure. So, and then it may be possible that resources are directed towards creating some outputs that are not priorities of the society. Again, you see, you have your production units, or it could be health facilities. So you are using some of the resources, and that's not priorities. Or if, for example, the investment to very high cost treatment maybe create benefits of very individuals involved, but it's not limited to the health system resources, could be better spent on other interventions that create larger health gains. So again, it all depends. We are talking about health gains. The gains of the outcome can be measured at the individual level. So the important thing to understand is that whether these resources are directed towards some of the outputs that if there is a larger benefit. So that could be the one reason that when an inefficiency may occur, and we can find out that it's an inefficiency. The other thing is like a misuse of inputs in the process of producing valued health system outputs. So if patients or medical tests are unnecessary, I mean, in some cases we say, well, if you are going to health facilities, you are given some medical tests, and individual patients are paying out of pocket. So in that case, if you are trying to think about the efficiency context of that providers at the facility level, it's not a kind of, and you say, well, we are providing the services, doesn't matter. But, think about the whole health system, that the health system, some of the resources are being spent. If you look at it in that perspective, that unnecessary resources are going, doesn't matter who is paying for it. I mean, that particular individual going for health care or to achieve that health services, and then the services being paid where there are unnecessary or duplicated the medical test or other investigations. And so that particular individual could have used that resources elsewhere, or could be, so that's that's an inefficiency also. So Zahid, next slide, please. Yeah. So these are the main possible reasons. So what I will do just to kind of bring up this concept, and then I'm leaving to Zahid and saying that, okay, Zahid Hasan can now take up to measures of technical efficiency. Okay, Zahid, over to you. Zahid.
Good morning, everyone. Thank you, sir, for explaining the theoretical aspects of technical efficiency. So by the time we know that efficiency means producing maximum output from a given set of input mix, as Zahid sir explained already, without any wastage of resources. So I'll not go in detail of the empirical aspects of efficiency analysis, but I'll try to give an overview on how we can use efficiency analysis technique in cross-country projects, as Zahid sir said, that we have a facility-related facility survey data, and which can be used for assessing the technical efficiency alongside the facility assessment. So let's start with a simple example. By the definition, we can see that, or we can say, efficiency or performance of a production unit is measured as output to the ratio of output to inputs. So, for example, if we have a few health service facilities or units like A, B, C, D, E, and F, and each of units have several doctors for treating patients. So in this case, the doctors will be treated as the input, and patients are obviously their intermediate outputs. So the numbers here, from here we can see that the ratio of these 6 units of service facilities. So the higher ratio means the performance of that unit. For example, here the unit B and unit F is higher. So if we plot this number into a figure, so just a simple figure, so we can say that the line here, the point B and F is the maximum level of productivity, or the output can be attained using the available resources for facilities B and F. So that line shows the maximum level of output given this with this facility. So we can say this is the frontier of like production possibility frontier, as already explained by Zahid sir. So this point, any point in this line for like this alongside with B and A, so any point in this line will be treated as a efficient production unit. If any like if C can come to this point, or if A can come to this point, so they will be treated as an efficient unit. But now currently these points are actually inefficient, and the lowest efficiency of among the 6 units of the D unit. So we can say that any point below this line is an inefficient unit. So the earlier example was only considered for single output and a single input. But if we have a real world situation, for example, we have in facilities we have multiple inputs. So like inputs are doctors, nurses, paramedics, and other non-medical staffs. They combine their effort in producing outputs, which can be the number of inpatient treated, or number of outpatients treated, or others like maternal cases treated, or ANC services provided. So in case of multiple outputs and multiple inputs, we cannot simply apply these ratio concepts to measure the performance unless we provide any weight with any of the ratio. For example, if we if we consider that one inpatient is equivalent to 5 outpatients, so then we can normalize the thing for it. So we can treat these outputs as one single output, or we can place weights for doctors and nurse, so to normalize in a single input. So but if we simplify applying the weight in a way, there raises other questions. So what weight should be placed for normalizing this to analyze the ratio, simple ratio analysis to assess the performance? So these challenges is overcome in applying two the technical, the analysis method. So first one is the stochastic frontier analysis, and the second one is the data envelopment analysis. These two efficiency analysis methods are commonly used in assessing technical efficiency at hospital level, technical efficiency of different production farms, that can be pharmaceutical units or any business organizations, or can be applied for assessing technical efficiency across different countries. So based on the unit of production, that can be a facility or that can be a country, the input and output variables will be different. For example, in a country context, we actually cannot compare the number of patients or number of patients as the output or number of doctors as the input across the different countries. So because the country level, the size of the facilities or the structure of the health system will be different, but we can compare like the final outcome, for example, the mortality rate or life expectancy as a outcomes, and per capita spending for healthcare as a input for assessing the country level technical efficiency. But I'll go a bit detail on the data envelopment analysis for facility level efficiency analysis. So so let me just briefly explain the stochastic frontier analysis. So the stochastic frontier analysis is a parametric approach which uses assumptions on the shape of the frontier and measures the level of inefficiency. On the other hand, data envelopment analysis is a non-parametric approach. So it's a linear programming based approach that actually do maximization or minimization of production function. Maximization in a sense of like maximize the output and minimize the input mix. So it can easily estimate frontiers with multiple outputs and multiple inputs case. So I'll go in detail about what can be the possible outputs and possible inputs for assessing technical efficiency in porous countries for at the primary care level. So data envelopment analysis identifies the point like B and F we show in the earlier graph for future examination or to serve as a benchmark to use in seeking improvements. For example, after identifying the production maximum level of efficient level, the other points, other facilities or units are compared, that how efficient they are compared to the best performing units. Here we have shown in the earlier figure that B and F were the best performing units. So I have also explained this, that any distance between this between the production point of a unit and the efficient frontier is due to the systemic inefficiency. So if inefficiency exists, the facility or unit will be below the production efficiency frontier. So data envelopment analysis have a set of assumptions that it actually based on the basic assumption of production function that every inputs or every outputs that will be produced from a production unit is associated with its inputs. And the efficiency score is defined as a ratio of weighted sum of input outputs to the weighted sum of inputs. And the score we get from applying the data envelopment analysis will be ranged from 0 to 1. And technically, efficiency units will have a score of 1, which means the facility or units is 100% efficient, whereas the inefficient units will have a score of less than 1, or that will be a less than 100% efficient. So a facility or unit will be considered technically efficient if it can produce maximum output given a set of input mix, as we already have known this. So there are common approaches. I tried to explain in the beginning that if we want to estimate efficiency at facility level, the input and output the variables will be different. So there are 3 common approaches, like subsector approaches, which focuses on the efficiency of a specific sector. That may be a pharmaceutical sector or healthcare facilities like primary healthcare or secondary healthcare facilities. And efficiency can be measured in disease-based approach as well, which focuses on the health gains due to specific disease treatments or any specific interventions. And it can be also conducted at a system level approaches, with the broad objective of overall health systems, which may be, as I said earlier, can be reducing the like mortality rate or under 5 mortality, and increasing the life expectancy or increasing quality adjusted life years. So those can be the output variables for measuring system level approaches efficiency. So for conducting technical efficiency, we have to we have a few issues to consider, that who is evaluating the efficiency of what entity, whether it is a hospital or it is a facility or it is a country aspects, and why the efficiency is being conducted, whether the analyzer or who the person or the researcher who is conducting the efficiency, whether he wants to examine the input mix, or whether he wants to examine the output mix and their level of efficiency. And we have to clearly define the output, which output is going to be measured, and what is scale that the output will be examined. And we also need to define the inputs, like what resources are producing that outputs, whether the resources will be considered are actually contributing to the outputs or not. And there will be some explanatory factors that are not related to inputs or outputs. So these can be internal factors such as ratio of bed to nurse or bed to physician in a facility, or some external factors that can be like population density or per capita income or poverty rate. These can also influence the efficiency score. So these are the 4 main things that we can consider while conducting an efficiency analysis. So I'm showing the commonly used inputs for assessing technical efficiency analysis for healthcare facilities. For example, if any of the poorest country we have data on capital items of the facilities we have surveyed. For example, if it have the data on a number of beds, or the size of facility, or medical equipment, or the labor inputs such as a number of doctors, nurse, lab technician, administrative staff, or financial inputs such as the total expenditure, capital expenditure, or salary expenditure. So if we have like a couple of inputs, this sort of information with us in our facility assessment survey, so we can treat those variables as the inputs for conducting efficiency analysis or planning efficiency analysis. And if we have these are commonly treated outcome variables. For example, the number of outpatient visit, as I mentioned earlier, also. So the number of admissions, number of normal deliveries, number of C-sections, or can be some outcome variable like avoidable mortality, life expectancy, so on. So for if we have any of these indicators in our facility assessment survey, then we can have, like from the previous slides, we saw that there might be this information we might have collected from facility survey, and we might have collected from the these indicators as which can be treated as outputs from facility survey. And there are others explanatory variables which can be estimated from the existing, if we have the data like bed occupancy ratio of the facilities, or the average length of stay, ratio of nurse to physician, ratio of sorry, it will be the nurse to doctor, nurse to bed or something. And there are some external factors we might collect, like population density, which will be the region in the facility where the facility is situated. There might have a catchment area, so there might have information on the population density on that area, or like unemployment rate, poverty headcount, or location or distance from any specialized hospitals or other hospitals. So these are actually the variables for we need to account for conducting technical efficiency using a data envelopment analysis. So how this will work? So we will, if we have those information, for example, we have 50 facilities in Bangladesh, and we have collected the data for 50 facilities. So we can use those information for like doctors, nurse, and admin staff for each of these facilities as input variables, and we can consider the inpatients or outpatient treaters of each of these facilities as output variables. So then we can apply DEA. So this can be the method. We can there are several approaches of doing this. In maybe we can do it in Stata, or we can do it in R. So that's the statistical process. We will use these variables and run the run in Stata or R. Then we will get some scores for against each of the facilities we have conducted, we have included in the sample. So if we have 50 facilities, then we will get 50 different efficiency score for each of the facility. And we may find that some of the facility have a score of 1. That means those facility are fully efficient, considering their input mix and their level of output they are currently producing. And some of the facilities might have a score less than 1, so those will be treated as inefficient facilities. And using this score, we can do some regression analysis, for example, TOBIT or truncated regression analysis, for considering the influence of different factors I have already mentioned, to see which of the factors actually influencing the efficiency score or related to the efficiency score in these facilities. Whether the density of, if the population density is higher, whether the facility is performing well, or if the ratio of nurse to physician is higher. whether the facility is performing well or not. So this kind of relationship and implications can be generated from the efficiency analysis, and which can be useful for policymakers as well. So while conducting analysis, two main things I would like to highlight that so if we conduct data envelopment analysis to analyze for assessing the technical efficiency, we have to choose the facilities which are similar in a structure. Similar in structure, I mean actually it will not be wise to compare a primary care facilities with a secondary level hospitals. So that because their input mix and their objectives of treating patients are different. So if we want to conduct a technical efficiency analysis using data envelopment analysis, we will choose those facilities actually similar in structure. I mean that those may be serving the purpose of providing primary health care. And so those can be this can be one issue. And another important issue is that input variables or output variables should be like whether they are input or output should be in the same scale. For example, if we consider input variables in 1,000 scale, so we have to convert all of the inputs in a 1,000 scale. And or if we want to reduce the scale by dividing the numbers, maybe because the number is very high, for example, more than 1 lakh. So we will have the similar scale for all of these facility, all of the inputs and output variables. So this is actually the basic smoke. I don't know how much it was possible to explain and how much it was understood by the listeners. And I will now share a lesson from efficiency analysis. It is basically from my PhD project. So I'll briefly overview that how we conducted this and what we found. So we assessed technical efficiency of Bangladeshi sub-district level hospitals using a data envelopment analysis method. We included 423 sub-district level facilities in analysis. So we used secondary data from different sources like health bulletin and explanatory variables, as I said, that from Bangladesh Bureau of Statistics and some information from the sample vital statistics. So using this secondary information, we conducted data envelopment analysis for 423 sub-district level facilities. For conducting this, we used input variables as the number of beds, number of doctors, number of nurses, and number of medical technologists. And as the output variables, we used number of outpatient visit and number of inpatient visit. And as an explanatory variables, we use population size, bed occupancy ratio, average length of stay, ratio of beds to physicians, ratio of beds to nurse, number of private facilities alongside the sub-district level facilities, and adult literacy rate. So using this input and output variable, we conducted the data envelopment analysis, and we used the output-oriented DA model. So I mentioned that the perspective is important, because whether we want to see that we want to maximize the output or output mix, or we want to reduce the input mix. So if we want to see, or if we want to examine, we will reduce the input mix because the availability of nurses or availability of doctors, which is not real in many countries. So in that case, we will have to use a input oriented DA models. So as our perspective was to see that using the existing level of resources, how efficient are the facilities, and what percentage of production can be improved to overcome the inefficiency level. We used Starter 16 for conducting the data envelopment analysis. And we found that on average, the sub-district level hospitals were around 58% efficiency, and that means the efficiency score was 58. And of the 423 sub-district hospitals included for the analysis, only 25 hospitals had efficiency score of 1. That means they actually structured the efficiency frontier, and they were in the efficiency frontier. And on an average, the inefficient facilities would increase their output by 42% using the existing level of resources. So that means there is a huge level of inefficiency in the sub-district level hospitals, considering their current input mix and output mix. And when examining the relationship with the efficiency score of external factors, we found that adult literacy rate, bed occupancy ratio of beds to physician, and ratio of physician to nurse had significantly positively associated with efficiency. That means that changes in this factor would increase the efficiency of any of those hospitals considered in this analysis. The findings of this efficiency study provided an empirical evidence on the technical efficiency of sub-district level public primary healthcare facilities in Bangladesh, and identified the several factors that were actually influencing the technical efficiency of the facilities. And most of the sub-district, as I said, most of the sub-district level hospitals were inefficient in producing healthcare services. And the average technical efficiency, about 58%, suggesting that there is a scope for overall improvement among the inefficient facilities by learning from the efficient facilities. So if the inefficient facilities can have learning that how the efficient facilities are operating, so they can improve their performance through this cross-learning process. So I'll briefly say, go through some of the limitations of the data envelopment analysis, and which are sometimes very crucial, because the data envelopment analysis, it works in a deterministic way, meaning that the results are entirely dependent on the numerical values in the data set. As I said, that we only treat with the number of inputs, number of outputs. That's only the number. So the number and nature of the units in the data set is highly sensitive to outliers. For example, if we can remember that we had efficient facilities B and F. So if they were, the two facilities were outliers, so other facilities will be, despite they were performing well, they would be treated as the inefficient facilities. This sometimes cause a problem in developing frontier and concluding the findings from a study. And another limitation is that the data envelopment analysis cannot apprehend the quality of services because it only depends on the numbers. So whether for example, if a facility is providing healthcare, whether irrespective of the quality, if it treats, for example, a huge number of patients without any maintaining any quality of treatment, so that facility can be treated as a very efficient facility, because we cannot apprehend the quality aspects of the treatment in data envelopment analysis. So that's all the presentations. Thank you for listening with patience.
Yeah, thank you, Zahid. That's been a lot of interest, and one thing I must say that we within Chorus, particularly, we have also people who has worked in this area of efficiency analysis. I can see Jacob is here, And I still remember I was going through some of these things, that improving primary healthcare facility performance in Ghana, as there has been a published study and an efficiency analysis and fiscal space of implications. So this also tells that how you can use this efficiency analysis. So coming to what Zahid has been presenting and some of the questions, and Zahid, if you can, I don't think you can see the question is there because you may be still sharing your screen. So, but I can read that out for you. That, particularly Jacob has asked this question: should the external variable enter the production function if outcomes used instead of outputs? And the other question also from Jacob is saying that using expenditure and physical inputs may lead to double counting, which is, of course, is really when we try to do these things, which is also this kind of a problem we face. So, okay, there are also other questions from Helen and Noemia, but would you like to answer these questions first, Zahid? I'll give it to you.
Yeah, for the Jacob, I can see the question now. So
okay, that's fine. Great. Yeah.
Not concerned. For the external variables in the production, so external variables does not enter into the production. So if in case of production function, I mean we can consider outcomes or outputs as a like measure of output. So because it actually depends on the perspective. So you cannot have outcome at facility level, I think, because all the outcomes are intermediate outcomes to get, but you can obviously consider outcomes. And using expenditure and physical inputs may lead to the list of output or input I have shown. Those are actually possible list of output. So we will avoid try which is actually considered. For example, if we consider expenditure as the input, we may not use the other aspects of facilities like human resources or medical equipments or like this, because the total expenditure is representing everything.
Okay, so I think you can see the question from Helen as well. So the facilities should be in the same type, for DEA. Would it be okay to include NGOs and government primary healthcare facilities, particularly, in case of Dhaka, what the ARC is doing, or the ARC Foundation has collected those data, and if you want to use that. So, what do you think, Zahid?
I think if actually as the owner of the providers are different, so still the NGO facility and government facilities, they are providing the primary healthcare, but their mode of operation is different. So I think it will not be wise to combine those because the structure, if you see the human resource structure or at government facilities and primary healthcare facilities in Bangladesh, these are structure of inputs are different, although the outputs are same.
Yeah.
I'm still not sure that whether it can be actually combined, but yeah.
So the basic principle is, if you're trying to make it a difference in the production function theory, that all farms are similar, but they are maybe not in the same efficiency level. So that's the main issue. Sorry to interrupt, Zahid. Yeah, please.
Yeah, thank you, sir, for this is the limitation I mentioned, that the efficiency and quality. I haven't find any way to balance two things like efficiency and quality.
Yeah.
As the DA cannot accommodate the quality issue in the analysis.
Yeah, so which is again, Noemia has really followed up those questions of Helen with respect to quality, and how do you increasing the number of outpatient visits can reduce the quality of these appointments, that the doctors need to see more patients in the shorter time. So how to deal with these possible adverse effects of efficiency.
It's
So, yeah.
I think it's a limitation of the methods we use still in the literature. So yeah.
Yeah, I think, that has been, okay. There has been a lot of question as well. So Bryony has reflect on the quality separately using output measures, captures the quality. So yes, I think more or less these questions are covered. Secondary data, how to deal with the capital expenditure or total expenditure and the proportion used for these analyses. Also another question. You want to say something on that, Zahid? How did you deal with the capital expenditure and total expenditure and the proportion used for these analyses? Yes, that happens always because, Zahid.
I mean, as I said, that if you want to use a total expenditure, so
Yeah.
I think you do not need to include the capital expenditure separately. So
Yeah.
if you consider the total expenditure of a facility as an input, so you can consider all as a total expenditure of facilities. And if it is the total operational expenditure, then you can include the capital expenditure.
Yeah. I think also there's some comments from team has given really good some suggestions that how could we in many ways efficiency analysis can be beginning of the terms of asking questions about whether there are differences in outputs per inputs. So it could be undertaken as part of the regression, external variables mentioned, but the qualitative, you could do some qualitative analysis to explore the differences. So maybe you can add some qualitative study. But anyway, I will leave it to Tim. If Tim, you want to come and say something, that's a really good suggestion from Tim.
Yeah. Can you hear me?
Yes, Tim.
Yeah. No, I was just reflecting on all the a lot of the comments actually, particularly around quality, and this big assumption really, which is that the outputs are similar quality, and I think there are a number of ways of dealing with that. One of them, I think Brian has mentioned this, is sometimes there are ways of tracking the quality of facilities, either by adjusting the output itself for some kind of using some kind of quality adjuster, or simply look at quality indicators across the facilities to see whether there are good reasons for thinking that there is wide quality variation, and if there is, then look at the relationship between quantity efficiency and those quality indicators. So I guess what I'm really saying is that DEA, SFA begin to ask questions about how the services are being produced, but probably don't give you all the answers, and you may need to do further studies, either quantitative studies or qualitative studies, to follow that up, because this quality homogeneity is really a very big assumption of the analysis. It doesn't render the techniques invalid, but it is a big assumption. It needs something that needs to be followed up in subsequent analyses.
Yeah.
Right. Okay. Sorry. If there is any more question, because I was just thinking about the watch. It's like I know we have had longer than an hour, but I have to leave at 4, so it's 4 o'clock already. But that was a really good, and Zahid, thank you very much. Really giving just a basic concept and giving up some very the critical issues around these efficiency analysis and using DEA, data environmental analysis. But as Tim was mentioning, stochastic frontier, there is also other methods and index being covered. So I think what the reason was bringing this up is saying that, well, data are being collected, whether it is possible to do within Chorus some efficiency analysis, and this is the concept, and we are happy. I was just discussing with Zahid yesterday and also this morning, Zahid, this is probably the idea, and let's see how many people are interested. So I will stop here, and if there is any other suggestion, otherwise I will end here. Okay, thank you very much. I think it's very useful. And I'm just, thank you, everybody.